Hi, I'm Dr. Faranak Kamangar, and welcome to the Future of Dermatology podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between.
Hi, we are back. We are at AAD 2026. A lot of great things happening, lots of excitement. I have given 2 talks on AI and updates in artificial intelligence. And over the next 2 episodes, I am going to give you a glimpse the things that we talked about. There was a lot of AI around this conference, very exciting. And of course, DermGPT was a hot topic. So I'm going to get into it. On the first talk, we talked about pearls in dermatology. So what are the top things that we can take away? I'm going to make this short and sweet and just go over some of the top things dermatologists should know in 2026. To give you a quick preview, I'm going to talk about diagnostic image-based AI and where that is. And where it is in the short term is it's promising, but not fully complete yet. Of course, what I'm talking about is the quest for melanoma detection AI. And it's getting better and better, but again, this type of machine learning is still a little bit limited by the training data sets. So that's, in short, the update in that sense, but very exciting use case, especially for global health applications. That's the most exciting frontier because, as we know, there's not that many of us dermatologists, and especially around the world, there are dermatology deserts, health deserts. So if we can solve those problems, it's going to be pretty helpful. All right. LLMs. That's my special place in my heart, part of AI, large language models. Of course, DermGPT is one. These, I think, are your highest area of leverage right now. These are tools that you should use as your thought partners, not just a search engine. So we'll talk about that. And then the next thing I want to focus on is you need to maintain your scrutiny with any large language model. Large language models are made to sound really good and be very convincing, but you really, really need to pay attention. So we'll cover a few marketing fallacies that could trick you. Next is prompt quality. We got to learn how to prompt properly. We'll do a few little slips on that. And then lastly, just to understand that we're not being replaced, we're at the center of the AI revolution. Much of the AI is being built on the digitized data that the House of Medicine has put together. So we're now hopefully reaping the benefits of that. I first started my talk on AI pearls in just reviewing this talk that I've given even in the past few years at the AAD and what a change there has been in AI just in the last few years. In 2024, I showed a slide where I talked about where artificial intelligence is, machine learning within that, unsupervised machine learning, and large language models being under that. I talked about GPT-3 at the time, GPT-4, and I had GPT-5 with all sorts of question marks like, it's coming, what's it going to show? Around that same time, DermGPT had about 3,000 peer-reviewed articles. Since then, of course, we have over 60,000. We have agentic layers. We've built a derm brain. So a lot of changes. In 2025, we were waiting for GPT-5 to come out, and then the reasoning AI models hit the table with OpenAI's O1 and O3 Mini, DeepSeek R1, and deep reasoning really took the AI large language models from truly just a interaction conversation to now really deep reasoning. That then led to what people thought, oh, what are we going to get artificial super intelligence? But really what happened is it wasn't about the smartest kid in the room or super intelligence. It was really about the most useful kid in the room, which ended up being the agents. Agents in comparison to LLMs. LLMs, you can have conversations. Agents are entities who will do tasks, who will do actual work. Agents are everywhere now in all different fields outside of healthcare, and they are entering healthcare in a very real way. So that is the next era of domain expertise. So quick view of where AI is in healthcare. We talked about the FDA-approved AI machine learning enabled medical devices. I've shown this graph over the last few years, and it keeps going up and up. So in 2026, there's a total of 1,430 total AI-enabled medical devices in all of healthcare. This is not just dermatology. Dermatology actually has very few. And then there were 183 new devices in 2025 of all healthcare, not just dermatology, of course. The biggest fields putting out AI machine learning devices are still radiology by far, cardiovascular, neurology, hematology, gastroenterology. Derm doesn't really make the list. We're developing lots of different AI, different stages, but as far as medical devices, we're not leading this field. And then again, we took a closer look at where melanoma detection and image-based AI and FDA-approved tools are. And again, we talked about this is going to be, if we can find melanomas and find skin cancers earlier, I mean, we all as dermatologists understand what an implication that would have, especially in global health and areas that have dermatology deserts where we're not present. Again, we looked at the FDA approvals. There's, Melifine, which is no longer available, Nevisense, Dermasensor. So far, those are the only FDA approved devices, but there's other ones coming right behind it that are under review by the FDA. Again, with these devices, they have a high sensitivity, meaning that they will pick up a lot of things, and that's good. We don't want to miss anything, but they have a low specificity still, meaning that they're going to lead to a lot of false positives. And so they're going to say a lot of things are maybe abnormal, whereas many of them might be normal and might lead to a lot of concern among patients, anxiety, referral. So still not, there's a gap, but that gap is getting shorter and shorter. And eventually we will have things that are pretty good as far as specificity and sensitivity. What does that mean for our workflow in our offices? AI and image-based skin cancer screening, some of it will enter the office, but really the main thing is that it cannot disrupt our workflow. This is pretty similar to full body photography. I mean, that's been around for a long time, but it hasn't entered in a real way. And because it takes time, it takes time for an MA or a nurse to take all the photographs, make sure they're in a system. And then when the patient comes back, bringing it up, looking at all the, analyzing everything. So anything that disrupts clinic flow, as we know, is not likely to get adopted. But I think if we can remove those barriers and make this a quick thing that's pretty seamless in the office, a lot of ifs there. But if we can do that, one thing I'm personally really excited about is this possibility of this longitudinal melanocytic monitoring, because there are many things I'm good at as a dermatologist, but remembering what a mole looked like down to the dermoscopic level 6 months ago is not one of them. But that's something that AI can definitely do better than me. So I think that's worth doing. Updates on AI use cases in general. This was a slide that I presented that was very packed, and this is a topic that could be talked about for 2 hours in itself, but just wanted to give a quick glimpse of the work going on. So first subsection is global skin disease. I mean, of course, again, like we talked about with melanoma or other skin diseases, if we can have AI kind of triage, screen, refer in underserved regions, that is a noble task worth doing. There's a lot coming out in the derm path, the kind of automation stages, also Mohs triage. Promising. What I find from our Mohs colleagues, they say that it's still pretty early in that space, and there are some differences there between how much data is available from frozen section versus H&E. So great things happening there. Research and drug discovery is a huge area that's being impacted by AI, and that's a great thing. We need more discoveries, more drugs, less time for targets to come out and actually help people. So there's lots of different targets and identified in atopic derm, psoriasis, HS, or inflammatory skin disease, AlphaFold driving biologic developments, a very interesting technology, and also deep visual proteomics. All very interesting technologies that I didn't go through in great detail, but great use cases and are really advancing, finding new therapies for us. Inflammatory skin disease was the next subset that we talked about. Now, we know there's a lot of severity scoring systems. We don't always remember them. They're not always easy to do. IGA, the EASY, SCORAD, PASI. What if AI could help with those? And AI absolutely can help with those. So those are going to make clinical trials and also in clinical space where we need these numbers, maybe, let's say for prior authorizations, those tools will be invaluable. And then there are studies coming out where you take genomics and clinical fusion models to try to identify things like psoriatic arthritis progression risk, or try to figure out your atopic dermatitis patient, what therapies would they do best with. So really interesting things coming out in the inflammatory skin disease space. And then lastly, I touched on the use case of sexually transmitted infections detection. Of course, this is a huge global health issue. It's not something that people feel comfortable coming to the doctor or have access to come to the doctor often, but imagine treating STIs better and preventing spread. That itself is an amazing use case. All right. So down to the large language models, the most powerful tool available today. Per me, and well, per the world, they're really, really helpful. So what I talked about is that if you're not using large language models, please start now. Large language model of your choice. You can really 10x yourself in terms of productivity and also some of your office members. So we talked about using it as your clinical thought partner. So you can talk to it for difficult cases, differential diagnoses, and you can really have a conversation. You can use it as a portal message drafter, right? Lots of messages come in and it can help you pre-draft. Again, you're reading everything and approving everything, but it decreases the cognitive load and decreases the minutes, which end up being hours when you're doing repetitive tasks. Prior auth specialists, that's a really good use case for AI. Patient education, this is an area that it really can excel in because it can change to different languages, different tones. Research synthesizer, so if you're doing research, evidence, looking up guidelines, great use cases. So there's so many things that can be done. And I talked about a use case of, for example, for in-basket messages, where if you can take a 3-minute task, turn it into a 30-second task by having something pre-written for you, then if you are doing that task for 3 hours, then that 3 hours becomes 28 minutes. So just to show meaningful decrease in having your hours given back to you. We talked about how large language models work, which is you take a large corpus from the internet, from text data, and you have the LLM train itself on it. You can also add a vector database through a RAG model, which is one of the parts of DermGPT, where we put dermatology information and it goes directly into the LLM. Of course, we've added much more since then in the agentic layers. And then what goes into generative AI is your data, your metadata, you tell it who you are, your role, and then it can sometimes remember your chat history. And then your prompt is really important. So all these pieces go in so that hopefully you get a pretty accurate response and you can decrease errors and hallucinations. And then what I talked about is that we really need to maintain our scrutiny, because AI is a tool, but it's not an all-knowing oracle. It's really important to understand that it can still hallucinate a lot. It can hallucinate even citations and make them look really real. So you have to really double check every aspect. You can have context blending, where it takes two different things and kind of blends them together because they sound the same, but leading to the wrong answer. It should not be making any clinical judgments. It's not ready for that yet. Might not ever be. Then you can have this silent degradation, where your RAG model just slowly starts reducing in performance, but you don't really quite see it yet. So the main point here is that you and your decades of training and experience plus AI equals a really extraordinary multiplier and a good thing. AI alone is kind of just a confident guesser, so don't give it more power than it's due. I also touched about a concept called kind of the journal halo effect that I like to call it. Another name I played around with is the prestige corpus fallacy. So basically, the journal halo effect is this concept where a lot of the larger LLMs put logos of really high integrity journals in their references. And there's something that happens when you see these high integrity journals and high impact journals with big names. You sort of instinctively take the ethics and impact of those journals and you assign it to that output from that LLM. Like, oh, it's that good because of, somehow associated with these references. But there's some truth to that. I mean, if you have better papers and you're going to get better responses out, There is some validity to that, but AI is so much more complicated. There's so much more that goes into a semantic search and a lot of places for it to go wrong. So just because it starts out with seemingly good data does not mean your output is correct. So you basically have to always read everything yourself. I showed this picture at one of my talks of this designer Balenciaga bag which is just basically a yellow trash bag. You guys may have seen this. It hit the news, but it does have the Balenciaga logo on it. So the analogy here was just because you see a good logo doesn't mean that your prompt answer is not just a trash bag. So really be very, scrutinize your answers and have just a really high level of you need to trust but still verify all the answers that come out. The next thing I talked about is semantic degradation and index crowding. These are a couple of concepts in a RAG model, which many of these larger healthcare LLMs are, that you can actually lose your efficacy. More is not better. What we found out with DermGPT, which is also corroborated by a lot of research at Google, is that the more articles you add to a vector database, sometimes you lose quality. We kind of found that your sweet spot is even between like 5,000 articles or so. And when you get way above that, you start to get the silent failure when things don't work as well. So there's a lot of pieces that go into a search. These are the little pieces we figured out over time, but they're important. So again, all of them meaning really verify the answers, make sure they're correct. Don't give up your expertise. All right. Then after I scared everyone of all the things that can go wrong, I talked about, well, let's optimize your relationship with AI because it really is great and it will save you a lot of time. So the first thing we talked about is stop using it like a Google. So, you don't want to just type a few things and search. You really want to have a conversation with it because that's the power of semantic search on AI models. Kind of use it like a medical student on your service or a clinical staff. Tell them exactly what you want and what you want them to achieve. With more direction, you're going to get a better output. You can also use them like a curbside colleague where you can think through a case together. Really helps with your cognitive skills. So the quality of your output is directly proportional to quality of what you ask as your prompt. So be specific, have a structured prompt. And the quality of your prompt is often more important than even which LLM you choose. And so we talked about the anatomy of a great prompt. These are just a few things you can do. One, make it a little bit longer, give more information. Most people use fewer than 9 words when prompting. The most effective prompts actually have 21 words or more in the relevant context. You can give it things like a persona. Tell it who you're trying to be. I'm a board certified dermatologist. Give it a task. State exactly what you need. I want you to draft, summarize, give me a clinical summary. Tell it exactly what you need. Context. What are we even talking about? Provide clinical details. I'm talking about a patient who was 45, Fitzpatrick type 4, on lisinopril. Just give more information. And then you could also specify format. I want this as a patient handout. I want it in one page. I want a clinical summary. I want a bullet list. You don't need to have all these elements at all parts, but when it makes sense, each element can add a lot to your output. Then we talked about some advanced prompting pearls. And the main thing with that is iteration and refinement. So keep prompting. If you don't like the first answer, say, change it to this, make this better this way, add this. And sometimes if you don't know what to prompt, ask the AI to give you a prompt. Say, I'm trying to achieve this task. What is a good prompt I can give you to achieve this? And the AI system will help you. Then I gave some examples of good prompts that are examples for dermatologists to have. These are things like a complex curbside consult, large prompts, but again, they're examples like I am seeing and give context to your case with what you're seeing. Please build me a differential for the top diagnoses, what distinguishes them, what targeted questions narrow this down, flag any can't miss diagnoses. Patient education, explain in patient-friendly language at a 6th grade reading level, include what it is, what to expect over time, how to manage it. So these are just different prompts. Evidence update, like what is a current evidence-based approach to said condition, and Patient portal response, have a prompt ready for that. Patient messages, draft a response for direct EMR portal use or prior auth appeals. So these are some prompt recommendations, and we can include a link below for some of these. But the major takeaways for this talk was, first, we talk about imaging AI. It's getting there, it's promising, but again, it's still not quite there as far as that sensitivity and specificity. Large language models are your highest leverage tool. So use them now, like right now. Maintain scrutiny. So we talked about the journal halo effect, index crowding. There's a lot of ways that your LLM could go wrong. So always evaluate it, make sure it's correct. Prompt quality equals your output quality. So make sure you are prompting correctly and giving a lot of information. Then lastly, just know that your expertise plus AI is truly unstoppable. There's nothing to fear with AI. The only thing I would say is if you're not using it, you could be losing out and having a lot of hours that you could be saving. So those are a few updates on AI at the AAD in 2026. The next topic, I'm going to go a little bit more into agentic workflows and what that means and what could be possible in the day of a dermatologist if you have a few agents in your system helping you out. Thanks for joining, as always.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.